You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle.
Hi, everyone. Welcome to an episode of the RC Executive Lounge podcast series. I'm your host, Praveen, and I'm super excited that you're all here. Today, I'm really thrilled to welcome Shawntea Garden, or as many in the healthcare community know her, Taya, the CEO and founder of Atlas Perpetua Healthcare Consulting. Taya is one of those rare voices in healthcare who combines deep operational expertise with a genuine passion for transformation. She's an educator, author, and keynote speaker who has dedicated her career to helping hospitals and medical practices strengthen their revenue cycle performance while creating more meaningful, human-centered change in the process. Through her work at Atlas and Perpetua, Taya partners with leadership teams to tackle everything from strategic planning and revenue cycle assessments to training, education, and coaching for managers and frontline staff. Her clients often describe her as someone who brings both clarity and courage to the table, helping them navigate complexity while building systems that actually work for people. She's also the author of 2 books on revenue cycle management, and she frequently shares insights on how innovation, collaboration, and continuous improvement can shape the future of healthcare. Ty often says, it's a great time to be in healthcare if you're up for change and up for a challenge. And if you have ever heard her speak, you know she truly lives by that message. Taya, welcome to the show, and thank you so much for joining us today.
Thank you so much for having me. What a wonderful intro. I'm honored.
Thank you. With that, let's jump right into our first topic. RCM and finance teams face a lot of pressure today from various quarters, from payer delays to staffing gaps. You have been the acting fractional CRO for multiple healthcare organizations. How do you go about thinking about and setting top strategic priorities for your organization when you are the fractional CEO in a healthcare organization?
Oh, good question. For me, it really all comes down to evidence, right? So I like to look at what does the performance data look like of the organization? What are the KPIs? How are we benchmarked against others that are performing, not just for things like days in AR, but also for staffing ratio sizes, right? And compensation for our staff and things like that. And when you start to look at the data, it starts to tell a story of your performance up to date and also maybe where there's some opportunities or some weaknesses. And those opportunities and weaknesses really become the foundation of any strategic plan. So for me, it kind of all starts with digging into the data, making sure we really understand the organization, which is also, I feel like I'm kind of uniquely positioned often because I haven't been there. I don't know the way they always did it. So when I come in, I'm able to put a unique lens on that data and help them create that strategic plan.
And when you had looked at the data and come up with a strategic plan, one of the interesting challenges that we hear from a lot of leaders is the data gives them sometimes a lot of opportunities, if any, sometimes too many opportunities, which means every organization, every leader has to make some really tough choices, right? So from your recent past, can you share an example of where you had to say no to a really good initiative in favor of something a lot more critical based on what you saw in the data?
Yeah, that happens daily. That I have groups come to me because they want to do something like we want to add a new ancillary service or we want to negotiate all of our payer contracts. And they're very excited. They're very driven to do those things, which is why they've reached out to me. Excuse me. And when I go in and I say, okay, the first thing we need to do is really understand where you're at right now, make sure all of that is stable. Let's pull some data, particularly for payer contracting. You can't just start doing that without knowing you're in a really solid footing from a revenue cycle perspective. And often what we find puts a halt to the entire thing, right? Maybe their days in AR are plus 100, or a group I just looked at today, their days in AR were way over 100. There's nothing else that we should be doing that takes away staff's time if we don't have our cash flow moving really quickly and unburdened, right? So there is probably probably an example I could give you daily or weekly on a group that has come to me because there's something that they want to tackle. But first, we have to clean up some of their foundational things first to make sure that they have the cash to do what it is that they're trying to do.
Makes sense. And when you look at the data, when you look at all these different initiatives, and you've looked at it a lot for a lot of different organizations, when we talk to leaders, we hear a lot about the importance of programs like denial prevention, patient financing, financial assistance. And we hear this a lot from a lot of leaders, but as well as when we go to major events like NGMA, HFMA, and all, we hear about all these programs a lot. When you looked at the data for all these different organizations, where did programs like denial prevention, patient financing, or financial assistance fit into your strategic priorities for those years?
Oh, they absolutely fit directly into their mainly because all of those things are going to impact your cash flow, right? So if we are not preventively trying to reduce our denials, then we're going to have more denials, which means more staff work, more cost for us to appeal those, slower revenue cycle velocity overall. And when we look at things on the patient side, if we don't have financing options, payment options, if we're not educating them in what their responsibilities are, again, all of those things just slow down the amount of cash that we have coming in. And it's really, really frustrating for organizations. And sometimes I find them kind of treating the symptoms of problems. So they'll say, well, our days in AR is 120 and our net collections ratio is only 50%. So we should increase our charges because we're not making enough money or it's not coming in fast enough. Or maybe we should stop working with this one payer that doesn't get the money in the door fast enough. And when you dig a little bit deeper, you often find that the problem is the way the claims went out the door. Or the problem is the patients aren't paying because they don't understand why they have a responsibility, or because they know that they have this bill, but they don't know how they're going to afford to pay it. And many of them don't even know that financial hardship programs exist in the healthcare industry. So it often comes down to digging really deep to the root cause. And then once you have that, doing all of the communication and the education necessary to apply strategy to keep your revenue cycle. Again, you want it as unburdened as possible.
Makes sense. A follow-up question on what you said just now. One thing we have observed is denials as well as patient financing, the needs vary quite a bit depending on the type of hospital and the type of patients that they cater to, but also the depth of knowledge on the financial assistance programs varies significantly from one hospital to another. So when you dug into data for various different hospitals, what did you observe as some of the major root causes for these problems continuing to linger in these different organizations?
I think there's so much that goes into it. It's hard to say one definitive reason across all of them, right? For a lot of them, it's just that they've never put a strategy in place before. Some of them have higher acuity just communities, right? Their patient population is sicker. Some of them have a patient population that is poorer, or maybe they have more barriers to care than another community. So it's difficult to say because oftentimes when you're dealing with the hospital, either they have created this homegrown thing and it's just worked over time, or they were really intentional about creating something that would work specifically for the needs of their community. But I would say usually if I had to pick one thing thematically that they all did, it would probably be not putting enough strategy around it, not being intentional enough to say, what do we think we're going to need to write off in terms of, financial hardships? What payment plans do we think our community is going to need? And then looking back at that data over time, how were our payment plans used? Do we have 5 of them and 90% of our patients used this one, So I think it really comes down to, like anything else, being intentional, creating that strategy, but looking at your own performance data to identify how that is going to fit with the needs of your organization.
Sounds like intentional strategy that is grounded on data or data-driven strategy is essentially what we're getting at. That's a really powerful insight. Taya, thank you so much. With that, let's take a really short break and we will jump to the next section where we'll talk to Taya about a challenging initiative that her organization had solved for one of her clients.
When care feels out of reach, patients walk away. Hospitals are left with denied claims and money they cannot collect. RCHQ's agentic AI cuts claim denials and helps patients set up payment plans that fit their budget, while connecting them to assistance programs like Charity Care and Medicare. Seamlessly integrates with your existing RCM systems with no coding required, empower patients, protect revenue, increase cash flow. RCHQ, every patient's trusted AI financial assistant.
Welcome back. Let's dive into a recent initiative that you and your organization led for one of your clients. What challenge were you solving for, and how did you arrive at that challenge being the topmost priority for the organization?
Good question. So there have been so many issues that we've been helping groups with lately. I would say one that was really interesting recently, we were trying to help a group really reduce the number of days that their claims were sitting in AR. Their days in AR were really, really far out. And when we started digging, their days in 120 plus were really high. And there were two competing factors. One was that they hadn't written anything off. So they had claims sitting in their aging that were in there for like 10 or 15 years. And at a certain point, things just need to come out of the system. You have to accept that revenue is not going to come in, and you got to get them out of there because it's improperly going to inflate your days in AR, right? So we helped them get that cleaned up. Another big issue that they had was that their payer database in their system was just bad. It was terrible. And I think that when they first set up their practice management system, when they first transitioned to it, whenever that was, they just started putting payers into the system. And it wasn't one of those systems that will automatically pull in the payer data for you. It was a lot of manual entry in their payer database, right? So they were typing in the carrier names and addresses, and then anybody who'd go to look one up wouldn't look for the same thing, right? So one person put in UHC, another person put in United Healthcare, somebody else put in United HC, and now you've got three for the same payer. But one might have a typo in the zip code, and one had a typo in the PO box. And so a lot of what they had sitting in their AR, it wasn't that the claims weren't going out the door with the correct information, it was that they were going to the wrong people. And so there was a lot when we ran this report of their AR and we really started digging into it. I said, you know what, I want to know for these payers, how many payers have their entire balance, 100% of their AR in 120 plus. And there was like 15 or 20 payers that were like that. And for all of them, we found duplicate, even triplicate payers in the system with the same name, same carrier code, but they just were not set up correctly. And I think another challenge for this particular group is for about 50% of their payers, they were submitting direct to payer and they weren't submitting them through a clearinghouse. Wow. So they had manual entry issues on the carrier database side on top of manual errors inherent to, something not scrubbing for you. So it was quite a challenge. We did eventually get them all cleaned up and squared away, but it definitely took some time.
Makes sense. And once you identified what can only be described as a fairly gargantuan challenge, how did you go about selecting a solution or a partner to fix this issue? I mean, this must have taken quite a bit of time to clean up and get to a stable state. What was your process in terms of either picking a solution or a partner or an implementation process to overcome this challenge?
Yeah, so it was nice in this particular organization because they had the bandwidth necessary to tackle it internally, and we didn't have to go through the process of vetting vendors. Sometimes you do, and that's fine. I think there's so many people out here doing great work. You don't need to reinvent the wheel. If there's a group doing things and they're compliant and they've got a good track record, by all means. This group had the staff. They had the ability to do it. And so it was really nice for us because we're like, let's go through. We pulled the report. We assessed what are duplicates, what need to come out of there, what's bad data. And then we were just able to turn kind of over work lists to them, remove these 200 payers out of the system for these, 400, go update them and get the correct information in. And while they were doing that, we were concurrently working on setting them up with a clearinghouse, getting that information all connected so that hopefully we would reduce that going forward. So by the end of, it was probably 4 to 6 weeks, I would say, from the start of trying to figure out what was wrong till we had them on with the clearinghouse. And it went so much better. I mean, their days in ARs dropped dramatically. We got the old stuff out of there. But in terms of process, it's really just figuring out what is the lowest hanging fruit and what is the most painful thing, right? It's that kind of that old adage, if you have a task and it's going to take you less than 2 minutes, just do it immediately. If it's going to take you a really long time and there's not really that much of a benefit, that goes to the bottom of your list, right? And so just kind of working that way to strategize which things are going to be top priority. And anything that was going to help them get paid faster was our top priority.
Makes sense. And you alluded a little bit to the implementation in your previous response. Overall, it felt like you started with a strategy in your mind, and at the end of 6 weeks, you executed on the strategy by going through the list of tasks. Were there any pitfalls or surprises or lessons that you did not foresee when you started those 6 weeks journey that you would like to share with our audience?
Man, that always happens. It always happens. And I am very OCD about projects. So I've got them all mapped out. I've got them on the Gantt chart. And then we have a template that we use for every project that's similar to each other. So we don't miss anything, that we did previously. And then we'll do like a post-mortem and go back and look and like, what did we miss? What did we change? And so I've been looking at some of the post kind of project completion data recently. And every single project has something. In this particular one, most of the things that we found that we were not anticipating we would find, people that had unauthorized access at the front desk, because one of the questions was, how did so many carriers get added? They were thousands of carriers in their system. So that was one of the questions, is how did so many get added? And I will tell you, one of the challenges, which you see in other departments, they had a former employee who was taught to do things a certain way, who taught a newer employee, and things started to get lost in translation, to the extent that by the time that they got to the person who was their front desk supervisor when we came in to help them, that person was 3 people away from who had originally implemented the practice management system. And she believed that what she was supposed to do was enter a new insurance for every single patient. She
Wow.
didn't know that she wasn't supposed to do that for every patient, that the carriers were already in there. And that's the way she was taught to do it. So that's the way she taught her staff to do it. And I did not expect that. But I will tell you, every project I go into, when you're lifting up rocks occasionally, you're just going to find a scorpion. That's the way it is.
That makes sense.
And so, yeah, it always happens. And, the way we just treat that is with grace and education. And I understand how you got there. We're not doing that again. So let's get a better, cleaner process. And let's remove some of the permissions to do the things we don't want people able to do, right? So we took those permissions from the front desk. We don't want them entering in the new insurance information. We left that under the authority of the billing department, and that helped quite a bit.
Makes sense. And a related question for this initiative, as you executed and ended the 6-week journey, you talked about AR days. Were there other metrics that you were measuring to track success? And what did the end result look like for AR days as well as for other metrics?
Yeah, we're not super far out from theirs yet. But I do know that their days in AR now are down around 46, which is fantastic because they were up over 150. So they're definitely getting better in alignment with where they ought to be. I think in terms of like other metrics, I'm always looking at things like, gross collections ratio, net collect ratio, the percentage of how much of your AR is sitting in which buckets. I want to see most of that shifted to the left under current, so different metrics like that. Once you start digging into the data and you're doing it consistently and you kind of get a feel for, what your data should look like and where your metrics should be, you really don't have to look at it for very long to know what's wrong and where to go find it. So it's pretty easy for me to say that because that's all I do all day long. If I'm not teaching, I'm looking at the data. But yeah, I think in terms of other ones, those are probably my go-tos. Average days in AR, denial rate, net collect ratio, things like that are going to give me the overall kind of vital signs of an organization.
Awesome, Taya. Great to learn about all these metrics. With that, let's take a short break. When we come back, we are going to jump into up-and-coming technologies in the healthcare RCM industry. Stay tuned.
1 in 5 hospital claims is denied. Behind every denial is a patient delaying care and a provider losing cash. With RCHQ's agentic AI, fewer denials mean faster reimbursement. Patients get payment plans that fit their budget and access to programs like Charity Care and Medicare. No coding required to make RCHQ work with systems you already use. With RCHQ, you see an instant increase in cash flow.
Welcome back. I want to shift gears into technology. Agentic AI is a topic that you hear everywhere, especially in the world of healthcare RCM. What role do you see agentic AI playing in revenue cycle, either in 2026 or when you look ahead over the next 3 to 5 years?
I'll be honest, I see it playing a role right now. There's a lot of different organizations out there that are more comfortable with AI that are entering the healthcare space, which is a little scary. Although I will say I lean into AI because I think we need help in this industry. Desperately, we need help. And so if there are things that we can put into place compliantly that can help us, I think that we need to start doing those things because there's more work than any of us can do in this industry. And I think we've learned that there's really no other help coming. So I think we have to lean into some of those things. What I'm really excited about are the things that take so much of the administrative burden off of the organization. So I've seen things like batch appeal agents and agents that will, log in and pull the policy guidelines on a medication or for prior authorization or for, running all of your eligibilities and connecting with patients, even on education. I was talking to a group not long ago, I think it was at the last conference, that was talking about just doing patient education and outreach and, why did you get this bill? What does it mean when you get this bill? And helping to make them more informed consumers of the healthcare industry, because as those deductibles go up, our patients become our payers. And so I'm a big fan of using AI in ways that help lift us up. What I'm fearful of is people using AI to lessen their burden without putting the proper infrastructure and framework around that, and without making sure that it's really compliant. I do have some concerns about that because I can't tell you how many clinics and hospitals I've gone into and administration found out that the providers were already using AI and they didn't know, right? Because it didn't go through anybody. They just added an app on their phone and now they're dictating their charts and there's no BAA and it's all these compliance concerns. So I will say I'm cautiously optimistic. I'm hoping that it will bring about some real systemic change, but I think we really, really have to be intentional about creating the framework for compliance first.
Makes sense. And are there areas in healthcare RCM where you think agentic AI specifically can truly shift the game? Not just incremental improvements like 5-10%, but real transformation in the form of like 5x, 10x.
I am really, really hopeful that that is the case. I'm really hopeful that that's the case. I would say one of the main areas for me that I hope that it can help is probably with physician documentation, not necessarily with coding. And I still think, in my personal belief anyway, I tell this to everybody, but I try to use AI like it's an intern, like it's a brand new intern to my organization, right? Be really clear in telling it what to do, give it all the proper instructions, make sure there's a fence around it, and then double check everything it said, right? Because we know that AI can hallucinate periodically, but I would love to see it get to a point where our providers aren't several days behind in charts, where they're able to have their lunch, where they're able to have their weekend, right? Where they're not terrified of not getting their notes in there, not getting them in there correctly. Or you have the, pendulum swing the polar opposite, the providers who have templated so much of their note that it's bordering on rote medical care. And it's creating that medical legal risk for them. So I would really love to see it reduce the burden for providers in that way, because if we can improve the accuracy of their documentation, then we improve coding, then we improve the results of our coding audits. And then when we submit our claims, they get paid. And if they get audited, we keep our money. You know what I mean? That downstream effect of that would be so beneficial to so many. I would really, really love to see something help to improve that without adding information that the provider did not do or did not say, and without creating a compliance concern.
Yeah, that totally makes sense. And one last question for the segment. What else are you exploring right now in terms of technology? Agentic AI is one that we hear a lot, but are there other up-and-coming technologies that you are personally watching very closely?
Oh man, outside of AI has taken up so much of my time because I feel like it has its own verticals even underneath of just being AI. Outside of that, there's a couple things I've been watching lately, which are Microsoft and Athena, I believe, are the two that have released updates that have embedded pieces of AI in the revenue cycle model. I haven't tested either of them, but I'm interested to see if other organizations are going to start doing the same thing. right? Where they build in and embed something that works well within the framework that they've put structure and safeguards on, and then providing that to this industry without additional cost, because this industry has been nickeled and dimed to death. And so if we can do something like that, I'm very interested in that. So it is still in the AI realm. It's more of what organizations are doing than anything else. But I think most of us are consumed with following AI as a technology.
Makes sense. And one last question to round up the segment. Sorry, I missed this earlier. You've been a fractional CRO for multiple organizations. You've seen the breadth and depth of the problem definition here. Is there one metric that you obsess over as a CRO that you look at every day in the morning, that if the metric doesn't look good, hell breaks loose?
Good question. If I could only pick one, I'd probably pick the net collect ratio. I would really love to pick that one and days in AR, because together it gives me a little bit more complete of a story. And then I would add in the denial rate too. But if I could only pick one, I would probably pick net collect ratio, because I think too many groups look at what did we get versus what we build, and you were never going to get paid what you build anyway. So we have to look at, of what you were eligible to collect, how much did you get, right? Of that allowed amount, how much did you collect? That's really what is telling us your performance on collections, not looking at total charges or looking at total adjustments. There's so many groups that I talk to that, they're like, our net collect rate, our gross collections ratio has gone down every year. And I'm like, well, you keep increasing your charges and you don't renegotiate your contracts. So that's what happens. But your net collect ratio, you want that one pretty solid. You want that one up in the 90%. And I don't often see that before I come into the door to help them.
What has been the average typically that you've seen across all your clients?
I would say most groups are somewhere between 70 and 80% on their net collect ratio. The ones that desperately need help are not. There's a group I'm in the middle of evaluating. I actually put it on pause to hop on with you. Their net collect is 49%.
Wow. Okay. And where do you see, like, what are the top 3 reasons why the net collect ratio could be that low? Let's just say if it's like 70, 75, where is the remaining 25 to 30 getting lost?
That's where we go look at the other data, right? So what are your days in AR? Is it just that it's sitting in your AR and nobody's working your AR? If the AR is also looking really great and your net collect is really low, then I want to know who's writing stuff off, right? So every time you add in another KPI, you get to tell a little bit more of the story. And I think the story somewhat begins with your net collect ratio. When it's that low, do we have money sitting somewhere in AR we just need to collect? Or has somebody been collecting it and it's not posted? Or did somebody adjust it off that wasn't authorized to?
Makes sense. Great set of insights. Thank you so much, Taya. Please stay tuned. Our last segment is coming up. We are going to be talking about some amazing leadership insights with Taya. Please stay on.
Every denied claim is money left on the table. Every missed payment is cash flow you may never see again. RCHQ utilizes agentic AI to lower denials, set up families with affordable payment plans, and connect patients to affordability assistance programs like Charity Care. Lower denials, expand affordability, and strengthen cash flow. RCHQ makes it possible with no coding required. Visit rchq.com today.
All right, let's resume. Taya, change is really hard, especially in complex RCM environments. RCM environments are inherently complex, right? So when you are coming up with these data-based insights and you define a strategy, how do you build momentum in your organization for change across your teams so that your strategy actually translates into successful action?
Good question. So I think the nice thing about the revenue cycle is that once you identify what's wrong, there's typically so many people irritated with the revenue cycle at that point that they're just so happy they know the answer, they're willing to do whatever they need to do to fix it, And I think a lot of that stems from in revenue cycle, it's really easy just to look at a symptom and not see the root cause. And so people will spin their wheels for months resubmitting the same claim over and over and over again, only to find out at the end of it that there was something wrong in their provider profile setup with the payer, And I think when we do the assessments that we do and the analyses we do, we're getting so down deep directly with the root cause that by the time we bring it to them and say, you've been fighting with this and this and this, but this was actually the problem, they're usually all in. The second piece of that, though, is making sure you have all the right people as part of the conversation, right? So you have to have whoever is leading your organization, you have to have the billing lead, you have to have somebody there from intake, because you do all still need to be rowing in the same direction. But usually once we come in with the data, we have the right people at the table, it starts to get really collaborative, and we see that change pick up really quickly because people get excited. There starts to be a little bit of hope with the revenue cycle again, as opposed to it just being same problems. Here's another day, just another day with appeals and denials all over my desk. It starts to become achievable and people get excited about that.
Makes sense. And Taya, you have been a fractional CRO in multiple organizations. Based on all the experience you have gained from these organizations, if there is one piece of advice that you were to give to another RCM leader or a CFO, what would that be?
I can only give them one. Put your allowable amounts in the system. There's so many groups, every group I go to, I think in my career, I've maybe had, I could probably count them on one hand, the number of groups that put their allowed amounts in their system. And that is what you get paid. It's so unlike in any other industry, there's no way you wouldn't know what you were due to get paid, right? Your mortgage company is never going to just accept you mailing them whatever you feel like. But we do that in healthcare.
Right.
We don't put the amounts in the system and then we just accept whatever they send us. And we're like, that's probably right. And we never go back and check it. And I think everybody I talk to is like, it's a lot of work to put the allowed amounts in the system. And it is. But you're not renegotiating your contracts every day or every month, right? You're probably doing them every year or every couple of years. And so putting them in there and letting the system capture underpayments and overpayments for you is massive. Because just like us, the payers have issues. Sometimes they'll have manual entry error, sometimes the wrong profile gets loaded. And I cannot tell you the number of groups I've gone to meet with that have been underpaid for years.
Wow.
And in the contract, it says, after 60 days of receipt of payment, if you haven't told us, then you have to accept what you were paid. Or the groups that are billing less than they're due to receive. And so they get paid less than they're due to receive. So if I can only give them one, please, please, please put your allowable amounts in the system. It's going to give you so much more data to work with.
Awesome, Taya. One last question to close out the day. What's a recent book, podcast, a framework, an Amazon Prime video or a Netflix video that you watched that had truly influenced your leadership thinking in the recent past?
Oh, good question. Well, I just started reading Leaders Eat Last, actually. It's on my desk. Leaders Eat Last by Simon Sinek, and I haven't finished it yet, but I love the idea that we kind of take care of our people first. I think in most situations, it's like the airplane saying, put your own oxygen on first and then take care of your kids. But I think in healthcare and in business, if you take care of your staff and you take care of your customers, who for us are the patients, then we end up doing well at the end of the day. So I do love that concept of we have to take care of the people that are taking care of our organization. And when we take care of them, they take care of us in return. So I'm not all the way through that one yet. I'll have to check back in with you and let you know what I think. But I did just get it, and it's been good so far.
Absolutely. And especially with everything happening in the economy, with AI, talks of AI, taking away jobs, there's even more anxiety in organizations. So the insight that you gave is amazing, because I think we need that kind of a culture more now more so than ever. So thank you so much for that insight. I think with that, we are closing today's episode. Taya, thank you again for all the amazing insights that you've shared with our audience today. You've given our listeners a lot of wonderful takeaways today. Thank you so much for joining us.
Thank you so much for having me. It was awesome.
You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle.